Are you feeling nervous about the SCA? Maybe you're not sure where you stand or you don't know whether you're doing the right thing. In this video, I'm going to show you a behind the scene of a coaching session with GP Trainee. We go over a palliative case. So make sure you watch this video until the end to know what are the common pitfalls to avoid and how you can get a clear pass. When it comes to the exam, do you see how you're presenting on this screen right now? Lean like this. It doesn't look good. If I pull my shoulders back and then I speak to you like this, how does it feel right now?
It feels much better.
Yeah. So be aware of that, because in the exam you might be doing things when it's stressful and then you just go like that. It doesn't look great.
Now, when I watch myself, it's like consulting like a GP.
Yes. Yeah.
It's not me.
You're not like a hospital doctor anymore. You're more like a GP now. That's good. Now, one thing I would say here is that this word that you're using, it doesn't sound really good. You say guys. Have you noticed you're using that word?
Yes.
I don't think it's really good to use it in a consultation. Like guys, it's something that you'd use with your friend. I think it's probably best if you don't use that word, because it makes it less credible. Less is more for you, Mo. All right?
Yeah.
If you can cut things, like keep the main primary things that you want to say in your message, because all these other words is going to distract people. When you say I'll prescribe morphine, I think the explanation is good, what you're saying with the side effects. How you can get it to a clear path here is explaining that would be for long-acting pain relief. But then if David has got breakthrough pain, I'd also like to prescribe Oromorph to top up. For a palliative case, if you think about it from an examiner's perspective, they would be concerned whether a GP will be prescribing the PRN as well. Otherwise, in the middle of the night, the patient is in a lot of pain, they don't know what to do. It's quite bad experience with a patient then. Okay?
Yes.
So if you are thinking about it, you definitely need to mention it, because what good is it to think about it but then verbalize it and then not getting the mark you deserve? So let's say this patient had agitation or couldn't sleep, then I would make sure I mention I'd also like to prescribe midazolam for agitation. That might help him. Or if he's having a lot of secretion, then I'd like to prescribe him Haricine. Are you feeling unsure about the SCA? Maybe you don't know what to do, or you don't know whether you're doing the right thing. If you'd like to get a free copy of the SCA Blueprint, click the link down in the description below to get access to the SCA Blueprint that GP trainees have already used and passed the SCA exam. It's completely free. Just click the link down in the description below to get access to it. It's really good that you acknowledge and give that receipt to the patient wife, and then you ask the following question afterwards. So I think the problem though is that you went into the pain like it's a bit too close. I would have asked a bit more open question.
Yes, that's very true, Erwin. I think the new strategy also after the following weeks after this video is I watched a lot of RCGP examiners doing cases on 14 Fish, the SCA package. They tend to, not always, they tend to start with psychosocial and then eyes and then the biomedical part. And the biomedical part is just like inquiring about the symptoms, one or two red flags and one or two differentials, not too many. So in my back mind, oh, he didn't ask about this and that. But in fact, it's not important to have sufficient information to move with the consultation. The important part is to consult as a GP is the psychosocial and eyes. So they tend to start with psychosocial and then eyes and then biomedical. Why they don't start with eyes, although some videos they started with eyes? Because it can sound like very eerily, there's no much rapport, and the patient may not open up.
You have to do it in a way that is natural to you. So it's important that in the exam you're able to do it naturally, so that it doesn't look like you're doing it in a way that's formulaic. So if you've already been using a system, you can make some fine adjustment But I would not change it drastically right now, because then you might find it quite difficult to progress.
Not a lot of, I know that there will be a lot of teams will be involved. I don't know, maybe the palliative team and then the district nurses. I just want some, a lot of plan so that not a lot of, disturbance for him. Just few and we have our schedule. And then, regarding the pain, how we are going to manage that at home and all these things.
So what this simulator has just said is really, really key here. What's happening here is that there's a lot of uncertainty. Since the patient was discharged from hospital, there's no clear plan and a lot of anxiety due to this uncertainty. So your job here is to go in, actually design a plan that's going to be customized to this patient's need, focusing on the pain control, and also looking at how is his wife supporting as well, like whether she needs any help, because it looks like it's quite a lot for one person.
Remember, I was talking too much.
Yes, yeah.
Now we are approaching the 3rd minute. I haven't said much.
Absolutely. I've seen that progress, yeah. And you see how it helps you when you talk less in data gathering? Because then the patient talks more or the wife talks more, you get more information. If you found this video useful, you might want to watch this video in which I go more depth on clinical management. Click the video to watch it. Take care, everybody. Bye-bye.